Good afternoon. I'd like to start by thanking the GIS leadership, and in particular, Dr. Abdullah, Professor Abdullah Shahab, and Dr. Musa Akbar for having me part of this. It's been a great half day so far, and I'm sure it will be excellent going forward. So I'm tasked with discussing cardiogenic shock, and the topic is shock diagnosis and matching types of circulatory support to patient needs. I think if we were to remember one slide from this presentation is this: cardiogenic shock in 2022 and 2023 remains one of the highest mortality condition in cardiovascular medicine. We have made significant progress in every aspect of cardiovascular medicine, but unfortunately, despite all the gadgets and technology, the mortality rate for cardiogenic shock, especially acute MI cardiogenic shock, remains in the range of 40 to 50%. This are a slide from older data, still mortality in the range of 40 to 50%. This is the most recent data from cardiogenic shock working group. And if you look, the mortality rate is still in the range of 25 to 45%. If a patient present with cardiogenic shock, this is data in the US, and acute MI, the likelihood of 50%. So one of those two patients will not leave the hospital. It's just amazing and mind-boggling to think that in 2023, two of our patients, 50% of the patient would not leave the hospital with all the advances that we've made. If the cardiogenic shock is due to acute or acute on chronic heart failure, that ratio is 1 to 3. So that should be the background of the conversation. I'm going to start with the case. The case is not going to be fancy like the CTO cases that they have shown us, but the case, I'm going to use the case to go back and forth and to make the points that we need to make about cardiogenic shock. So the patient is a 55-year-old gentleman, history of dyslipidemia, intermittent smoking, and prediabetes. And you see on his EKG, he has extensive, this is about 1 o'clock in the morning, extensive anteroseptal with lateral extension, ST elevation, myocardial infarction. Nothing fancy about the angiogram, except he's a gentleman that he works with his hand. He specifically asked me not to do radial. Maybe in retrospect, he was smart to ask me not to do radial access, and you will see why. Right coronary node disease, the LAD proximally occluded. His pressure, as we call borderline, in the range of 90s. He's okay, he's almost okay. Let's see how he does. PCI of proximal LAD, no issues. But as I'm doing the case, these are the questions that are going through my mind. Does my patient need a mechanical circulatory support? And if yes, what kind of MCS? Should I have placed the MCS before I started the case? How long should I continue the MCS? And what parameters should I monitor while I have this patient in CCU and with a mechanical circulatory support? Well, if I am going to use a mechanical circulatory support, I need to know them, and I need to identify whether this patient has predominantly left ventricular failure, right ventricular failure, combined or associated respiratory failure. Some patient may have LV, RV, respiratory, and there are a combination of all these three. Obviously, if I have all the gadget at my disposal, balloon pump, Impella, right ventricular Impella, ECMO, tandem heart, then I need to know the indications and also the potential contraindication and complication of this. And again, for the sake of time, I will not go into detail of each device specific, but needless to say that identifying whether the patient has LV, RV, or combined failure, plus minus respiratory failure, and knowing the devices that would best match your patient is of paramount importance. One thing we know for fact, a protocol-driven care in the patient with cardiogenic shock works, even though not randomized trial. Several data, including data from National Cardiogenic Shock Initiative in the US, this is run out of Henry Ford in Detroit, where I trained and did my structural heart disease training. Protocol-driven, knowing what steps, what to monitor, it works. Compared with the prior database, the survival rate in cardiogenic shock And the registry of similar cardiogenic shock reaches 70–80% compared to 40–50%. While taking the caveat, knowing the caveat that this is not a randomized trial, the data does suggest that there is significant improvement when you follow a strict protocol. And there are three messages, number of them, but three important messages from National Cardiogenic Shock Initiative. That while inotrope make us feel better, while putting a patient on norepinephrine, epinephrine, or dopamine improves the blood pressure and makes us feel better, that's actually not a good thing. So the data suggests that the more inotrope the patients are, the likelihood of their survival is actually less. It may be reflective of the disease process that they have, and that's likely at least partly the case. But if they are on more inotrope, even though their blood pressure looks good, they are not good. That's number one. Number two, their cardiac indices, and specifically here, the cardiac power output, and I will show you the data on cardiac power output. So the cardiac power output, in order to have it, we need to know what is mean arterial pressure, easily attainable in the cardiac cath lab, what is their cardiac output, and the constant. And we can calculate cardiac output on the spot in the cath lab. So if their cardiac power output is more than or equal to 0.8, and they are on no inotrope, the likelihood of a patient with cardiogenic shock surviving and going home is near 90%. While if they are on 2 inotropes, 2 or more, and their cardiac power output is less than 0.6, the likelihood of going is 35%. So significant difference, and of course there are somewhere in between. Similarly, having a lactate, so end organ perfusion. So if your lactate is more than 2 and specifically more than 4, and your cardiac power output is less than 6, again, the survival of patient with cardiogenic shock in the range of 30% compared to 90%. So minimum, the data suggests that if tomorrow I have a cardiogenic shock patient, if I can ensure with whatever modality that the cardiac power output is more than 0.6 and the lactate is less than 4 or less than 2 ideally, then that patient will do well. And on the other spectrum, the patient will not do well. So going back to our patient, I am sorry to say, in this particular patient, at that time, I could not provide you a lactate. We did not have a point of care assay in the cath lab saying, this is my lactate level. So I do not have the lactate, but I do have the hemodynamics. That's the other. Going back in years, there was discussion whether we should do right heart catheterization or not. And routine right heart catheterization has been abandoned in patients going to cath lab. Specifically in cardiogenic shock patient, it provides significant data on how to manage these patients. So these are the hemodynamic of the patients. Based on those hemodynamics, the cardiac power output is 0.56, less than 0.6. And the PAPI, which is pulmonary arterial pulsatile index, is the index of right ventricular failure, helping you decide whether there is RV shock or no. This patient did not have an RV shock, but did have predominant left ventricular failure. So based on this data, knowing the cardiac power output, knowing that I was already on one vasoactive drip, I decided that I need Impella CP based on the data from Cardiogenic Shock Initiative. Guess what? At that time, at 3 o'clock in the morning, I did not have an Impella to place in this patient. So my first choice was out. So we put an intra-aortic balloon pump. Did I do the right thing? Did I provide the best care to this patient? I'm not sure. The data would say probably not, but that's what was available to me at that time. This is the clinical case. Patient was in ICU for a number of days. He was on ventilator support for a number of days, vasoactive support for 36 hours, balloon pump for 48 hours. His initial echo was in the range of 25% EF. Subsequent EF was 30–35, and he was discharged 6 days later. He's doing well clinically, but his EF is 40–45% by echo, and MAGA scan 43%. Not in the range of requiring ICD based on guidelines, but nevertheless, he did get a hit to his anterior wall, as you can see from the Q waves on the ECG. When we speak about the cardiogenic shock, we need to be on the same level. We need to be discussing what cardiogenic shock. If you look at the clinical trial on cardiogenic shock, every paper, every cardiogenic shock, they describe the cardiogenic shock differently. Systolic blood pressure less than 90, systolic blood pressure less than 100 on one vasopressor, on two vasopressors. And that, I think, the source of confusion. Earlier, we were talking whether the export catheter or aspiration works in acute MI. We don't know because we have put all the patients together, those who have grade 5 and those who have grade 1 thrombus. This is the same story. A patient whose blood pressure is 95 and a lactate of 1, maybe cardiogenic shock, but it's different from somebody whose lactate is 7 and his blood pressure is 70. Those are all cardiogenic shock. The SCAI initial paper in 2019 and subsequent position statement in 2022 gives it more granularity, provides the stages of A to E. A would be at risk and E is extremis. And each of those stages have a specific criteria for blood pressure, for lactate, for heart rate, and for biochemical marker to decide where your patient is. So if I call a cardiac surgeon and say, I need help with regard to ECMO, I'm going to say, I have a cardiogenic shock patient who came in a stage C and now is in a stage D. If I say cardiogenic shock, he can ask me what stages, because how sick is your patient that you're calling me at 4 in the morning? The data from cardiogenic shock working group published just a few months ago in late 2022 gives it even more granularity, specifically for stage B. It turns out that staging is not only important, it is also important if the patient goes from one stage to the next stage. So if the patient comes in a stage C and stays in a stage C, patient will do better outcome-wise than if the patient comes in a stage B and we do not act and the patient goes into a stage C and a stage D. So a staging is important, but also making sure that we're not dragging our feet so the patient goes from a stage B to C to D and then deciding, okay, do we need to do something? What may or may not work in cardiogenic shock? How about intra-aortic balloon pump, multi-vessel PCI, a standardized protocol for cardiogenic shock? I think the details of this thing is important. Well, we know the intra-aortic balloon pump shock 2 trials suggested that the balloon pump doesn't work. Does it really doesn't work? I'm not sure. In the patients that were studied in this particular study did not work. Is there a patient who may benefit from intra-aortic pump? Potentially, but not those patients who were, not all of those patients who were enrolled in this clinical trial. How about multi-vessel PCI? Well, multi-vessel PCI, based on this, both American Heart Association, American College of Cardiology, and the European guidelines downgraded doing multi-vessel PCI in primary setting from class 1 or 2A to class 3. Is that really accurate? Again, I'm not sure. The patients who were enrolled in multi-vessel PCI, they had LV dysfunction. Did they need a mechanical circulatory support? And if yes, should we be placed before or after? The answer is, I don't know, because the data is not there. Here is the multi-culprit shock trial. You know that the data suggested either the same or higher risk of death and renal replacement therapy. And based on those, the guidelines were changed. One thing we know that, again, protocol-driven care in cardiogenic shock, what to put, when to put it, what to monitor, how often you monitor. We don't, in ICU, there is no septic patient with septic shock that we do not check their fever and white cell count. But how can we take care of a cardiogenic shock patient and not monitor the lactate level every 4 to 6 hours? And that's the point of taking care of cardiogenic shock patients. This is the protocol that was used by a National Cardiogenic Shock Initiative. And the concept that they proposed was door to support rather than door to balloon. And but with those protocol in place, they showed significant improvement in the outcome. The main issue with the shock trial is that treatment is not specified. If we do not read the IABP shock 2 trial in details, we don't know when they put the balloon pump. Did they put it before or after? Did they put it after the patient crashed or after they were done with PCI? The same thing when balloon pump is compared with Impella. When should we put it? Most patients from cardiogenic shock die not from their shock, but from the sequel of shock, which is multi-organ dysfunction, which is renal failure, liver failure, neurologic dysfunction. And we need to prevent those before that happens. The Recover 4 trial is currently enrolling. So I have one slide that I need to show before. Thank you. I know my time is up. Perfect. Thank you. Otherwise, I will be in trouble. No.
Can you show the slide?
I'm sorry? Oh, yeah. This is it.
Okay.
God bless you. Thank you. So in order to change this, we need data from high-quality randomized clinical trial, and we need a standardized protocol for treatment of patients with cardiogenic shock. And this is my final and my most important slide. And the conversation that we have had, I've had with Professor Shahab and Emirate Cardiac Society is to think of establishing the Emirate Cardiogenic Shock Working Group and Emirate Cardiogenic Shock Initiative. And this initiative and this working group has 4 pillars. The 4 pillars include society guideline given by Emirate Cardiac Society, multi-facility experts, so everybody in the UAE would be shareholder, would include interventional cardiologists, clinical cardiologists, cardiac anesthesia, cardiac surgery. So it would be a multidisciplinary team. It would require unbiased industry support. That would be vital. And it would also require support from insurance and payers. Thank you.